Welcome to PGOG, postgraduate class in obstetrics and gynecology, and today's topic is pelvic organ prolapse, the surgical anatomy and supports. Definition of pelvic organ prolapse is descent of one or more of anterior vaginal wall, posterior vaginal wall, uterus, or apex of vagina, where it is called as vaginal vault or vaginal cup scar after hysterectomy. Supports of vagina have been described by D. Lancey way back in 1992, and these are being accepted at present all over the world as important supports, which were divided as level 1, level 2, and level 3. Level 1 is the support at the uppermost part of the vagina or upper one-third of the vagina or apex. So it is called as apical support, and this support is provided by uterosacral cardinal ligament complex. These are the two ligaments, uterosacral ligament and cardinal ligament, which is also called as transverse cervical ligament or McInrod's ligament. Level 2 support is at the mid-vaginal part of the vagina, at the middle one-third of the vagina, and it is provided from anterior and posterior vaginal wall fibromuscular layer attachment to the Arcus tendineous fascia pelvis. Now, for postgraduate students, you must remember these correct terminologies. That it is the fibromuscular layer of the vagina, which is being attached to Arcus tendinous fascia pelvis. Level 3 is the support at the lower one-third of the vagina, and it is that is why it is called as outlet support, and it is provided by perineal membrane and perineal body with its attached muscles and connective tissue. Now, some terminologies have changed over the years. If we see the previous textbooks and the latest textbooks, or even if we see the articles on internet, there is a change in terminology. Perineal membrane is being used at present, which was previously called as urogenital diaphragm, and there the students you might get confused if you read one textbook where it is written as urogenital diaphragm and another one where it is written as perineal membrane. That is why I am trying to make it this point clearer for you, that urogenital diaphragm and perineal membrane are one and the same, but the current terminology which is being used is perineal membrane. The reason is diaphragm is usually a structure which has muscle in between, and it is covered on both the sides by fascia. For example, pelvic diaphragm where we have levator muscle, and it is covered by superior and inferior fascia, and that is why it is a correct terminology to call it as pelvic diaphragm. This levator muscle forms the pelvic diaphragm, whereas here there is a doubt about presence of a muscle in this urogenital diaphragm. The doubt is about the presence of deep transverse perineal muscle as per the histological studies. And so the terminology has been replaced and it has been renamed now as perineal membrane. Now, vaginal fascia, which whenever we do vaginal hysterectomy or even sometimes abdominally also, what we appreciate is there is a layer which is most superficial layer of the vagina, which you can separate, and that is why we call it as a vaginal fascia, which is usually identified by vaginal surgeons also. It is now called as fibromuscular connective tissue of vagina instead of fascia. The reason is fascia indicates presence of fibrous tissue, but vaginal superficial layer has fibrous as well as muscular tissue. And that is why the terminology has been changed from calling it as fascia to fibromuscular connective tissue of vagina. It is the most superficial layer which is surrounding the outermost part of the vagina. Levator muscles are the main form one of most important support, pelvic support, and levator and muscles are support. They do support at all these three levels. That means apical level, mid portion of the vagina, and lower portion of the vagina. At all these three levels, though we have seen D-lenses supports as level 1, level 2, level 3, what is most important to understand is levator and muscles are supporting all these three levels. And how it supports it? It supports it by narrowing the genital hiatus, or it is also called as a levator hiatus or opening. So because of the uh, good tone of levator muscles are constantly in a state of good tone or contraction, and because of that, this opening through which vagina, rectum, and urethra are passing, these are all this is together, it is called as levator hiatus or urogenital hiatus, or better terminology is levator hiatus. And this, because of the good tone of levator muscles, this hiatus or opening remains narrow. That provides support to the uh, uterus as well as vagina at all the three levels: upper level, mid level, and lower level. Levator and ani muscles, they support it. Another way they support these pelvic organs is by creating an almost horizontal and posteriorly inclined vaginal axis. If we see vagina in standing position, it is not vertical. It is in a horizontal direction, and it is directed towards sacrum, posteriorly inclined. And what is the advantage of this is, because of this almost horizontal position of the vagina, though there is a raised intra-abdominal pressure, the vagina will not descend down. The pressure will not be transmitted in a vertical axis, and that helps in the support for the vagina to remain in the normal anatomical position. Levator are the two muscles from both the sides, and they are like a shelf. If you see a bookshelf with a closed door, so that door is like this levator muscles, and contents of the shelf are all the organs in the pelvis, such as urethra, bladder, and uterus, cervix, vagina, and rectum and anal canal. All these structures. So these are like structures which are present. Say, for example, if there is a bookshelf, you put so many books inside, and then you close the door. That door is these two levator muscles. So it is levator are like a shelf, and levator hiatus is like a cleft in two parts of the shelf. Suppose there is a gap in the two parts, that is the cleft. That forms a levator hiatus. And through this levator hiatus, what is penetrating is the anterior most is the urethra, then comes vagina, and then comes rectum. Diagrammatically, we can see here the levator muscle are like they have a shape like a funnel shape, so that they arise at the higher level, and then they enter, they go towards the midline in a downward direction. So this is the direction of the fibers, that levator muscles, which are formed by the pubococcygeus and iliococcygeus muscle. These are running in this downward direction towards the midline. So that is why it gives a funnel shape to the uterus, and it forms a sling-like structure. It is like a shelf, closed door of a shelf. There is a gap in between, or a cleft in between, through which all these openings, all these tissues such as urethra, vagina, and the anorectal complex are piercing it and passing down. Now, suppose you imagine that this shelf, door of the shelf is made up of a cloth, and after a few years, the cloth loosens. With the wear and tear, the cloth loosens. Same thing happens with the levator muscle fibers also. With the loosened tone, what is happening is, because the tone has loosened, there will be a increase in the dimensions of this levator hiatus, or there will be widening of the levator hiatus, as you can appreciate. As compared, this is normal, here there is a widening. Once there is a widening, then all the pelvic uh, organs which are superior to this levator will start protruding down, and that is how pelvic organ prolapse will start. Now, this is the diagrammatic representation where I want you to understand the relationship between the this pelvic diaphragm formed by the levator muscles and the perineal membrane, or older terminology is urogenital diaphragm. So what is happening is, as you can see here, this is the levator muscle which is going in a funnel shaped manner, and it is providing a sling to all the three tubular structures, to the urethra, to the vagina, as well as to the anorectal canal. It provides a sling for that, and with the good tone of levator muscles, all these are getting, with the contraction of muscle, all these are pulled towards the pubic symphysis in a normal position. When there is no prolapse, that is what is happening, and there is almost closure of this vagina because of the good tone of levator muscles, and all these are pulled towards, anteriorly towards the pubic symphysis. That is how it forms, levator muscle forms the main, it is forming the pelvic diaphragm, and together this levator this pelvic diaphragm and this perineal membrane is called as the pelvic floor. So that is first thing I want to make clear concept wise. What is pelvic floor? Pelvic floor is the structure which is formed at the base of the pelvis because of the presence of these two structures. One is the pelvic diaphragm and other is the perineal membrane. Pelvic diaphragm is formed with the combination of these levator muscles. Levator muscles are mainly pubococcygeus and iliococcygeus, and separately some books are mentioning levator muscles along with coccygeus muscle are forming this pelvic diaphragm. Coccygeus muscle is also called as ischio-coccygeus muscle. So together all these three muscles along with the fascia, superior and inferior fascia, this is the mainly the pelvic diaphragm. Below that is the urogenital diaphragm, which is now called as perineal membrane. Together, this blue and red together are forming the mainly the pelvic floor. Pelvic floor through which is mainly supporting all the pelvic organs. Now here, as you can appreciate, this perineal membrane is not extending completely up to the posterior part of the perineum. It is only occupying the anterior triangle. It forms the anterior triangle. It forms the anterior triangle, this perineal membrane, which is arising from the ischial tuberosity, and then it goes and it is present. It goes midway only and gets inserted in the pubic symphysis, and that is how it forms the anterior triangle. Posteriorly, what is there is mainly the anal triangle. It is called as anal orifice, and surrounding structures around the anal orifice, such as external anal external anal muscle, internal anal muscle, and together these are forming the anal triangle or posterior triangle of the perineum, whereas anterior triangle is formed by this perineal membrane. That is the reason only two tubular structures are piercing this perineal membrane, that is urethra and vagina, whereas this rectoanal canal, anorectal canal, is not piercing. It is piercing only the levator muscles, or it is only piercing the pelvic diaphragm. So pelvic diaphragm is pierced by all these three, whereas perineal membrane is pierced by only urethra and the vagina, because it remains only in the anterior part of the perineum. Now, concept about levator plate. What is levator plate is this pubococcygeus muscle. As it starts from pubis and goes to the coccyx, it is encircling all these three structures, and that is why we say some fibers of pubococcygeus as pubourethral sing, pubovaginal fibers, and puborectalis fibers. All these are part of pubococcygeus muscle only. And iliococcygeus, it goes posterior to the rectum, and then it goes to the, it gets inserted into coccyx, this blue part, and this forms in the midline, these two iliococcygeus muscles behind the rectum fuse with each other, and there is a fibrous structure, and this fibrous tissue is called as levator plate. So levator plate originates from iliococcygeus muscles, whereas this pubococcygeus muscle contraction leads to the shift of all these three, urethra, vagina, and anorectal canal. All these three are shifted anteriorly towards the pubic symphysis, and behind rectum, transversely placed, is the fusion of iliococcygeus muscles with each other in the midline, forming a fibrous band that is called as levator plate. So pelvic diaphragm is levator muscles and coccygeus muscle along with superior and inferior fascia. Superior fascia is the fascia covering the superior aspect of the levator muscles and coccygeus muscle. Inferior fascia is covering the inferior part. It is the fibrous tissue which is covering it, muscle, and in between is the sandwich, is the muscle, and that is why we call it as a pelvic diaphragm. Good tone of levator muscles act in two ways. First is because of the good tone, the levator hiatus remains narrow. That is most important function. Second is because of the good tone of this levator muscles, the vagina remains in almost horizontal direction and with a posterior deflection, or the direction changing towards the sacrum. And that is how, because of this horizontal direction also, these levator muscles contribute in providing support to the vagina. Now we will see each level of the support as given by D. Lancey. Level 1, apical support is provided by this uterosacral cardinal ligament complex. Now what are these ligaments? Uterosacral ligament, all of you must have seen while doing hysterectomy. If you give a traction over the uterus and pull it anteriorly, then two bands of the uterosacral ligament they do stand out. So, and laterally also, if you palpate, there is a thickening just lateral to the cervix and upper vagina, that is cardinal ligament. These ligaments are nothing but the condensation of endopelvic fascia or connective tissue, which is surrounding the vessels and nerves passing in that region. So, perivascular, vascular and neuronal tissue, or condensation of loose areolar tissue, it leads to the development of these ligaments. Though we call these as ligaments, these are not joining two bones. Now, usually in the body, whenever we say ligament, these are usually joining two bones, whereas these are not joining two bones. These are extending from cervix and going to the lateral pelvic wall, which is being covered by the obturator muscles, and posteriorly to the sacrum. They connect lateral wall of lower cervix and upper one-third of vagina to lateral pelvic wall by cardinal ligament and to the sacrum by uterosacral ligament. These cardinal ligaments are not directly getting inserted in the pelvic wall. They are getting inserted into the obturator muscles which are covering the lateral pelvic wall. Uterosacral ligaments have smooth muscle, connective tissue, blood vessels, and nerves in it, whereas cardinal ligaments have only the connective tissue which is surrounding vessels and nerves. It is not having smooth muscle element. Cardinal ligament is not having any muscle element, whereas uterosacral ligaments have smooth muscle as the main component. Cardinal ligaments are almost vertical when a woman is in standing position. Though always we describe or draw these as transverse cervical and going transversely, that is in lying down position. In standing position, they are almost in a vertical fashion. Like levator are also going in as a funnel shape. Same way, these cardinal ligaments are also almost vertical. Both these ligaments provide support to the uterus and to the vagina, especially at the apex of the vagina or at the upper one-third of the vagina. Here diagrammatically we can see This is blue one is the cardinal ligament, which starts at the cervix and then it is going to the downwards. It is almost vertical in the standing position, and then it is getting uh, attached to the uh, obturator muscle, which is covering the lateral pelvic wall. Whereas uterosacral ligaments, they are initially narrow. It has a smooth muscle component, then it fans out and then it is getting inserted into the sacrum. It forms the lateral border of pouch of Douglas. Here is the pouch of Douglas. As we know that when if you look at the this uterosacral ligaments from above or abdominally, and you push the uterus towards pubic symphysis anteriorly, then these do stand out, and the area in between these two uterosacral ligaments is pouch of Douglas. So these are forming the lateral border of the pouch of Douglas. These are supporting not only the lower part of cervix but also upper one third of, providing a support to the upper one third of vagina, apical support. Level 2 delancey support is to the middle portion of the vagina or middle one third of the vagina, and it is provided because there is an attachment between the fibromuscular layer of vagina with Arcus, tendineous, fascia pelvis. Fibromuscular layer of vagina we have already seen. It was previously called as vaginal fascia, but now it is called as fibromuscular connective tissue of the vagina. This it fuses with Arcus tendineous fascia pelvis. Now, what is this Arcus tendineous fascia pelvis? It is also condensation of pelvic fascia, which runs medial to levator muscles from ischial spines to pubic symphysis. So, it is also condensation of endopelvic fascia actually. Endopelvic fascia, the facial tissue which is present in the two leaves of broad ligament as well as everywhere in the pelvis, all the pelvic viscera are surrounded by loose areolar tissue, that is called as this endopelvic fascia. And this condensation of this endopelvic fascia leads to the development of this Arcus tendinous fascia pelvis, which is attached to ischial spines on one hand and just lateral to the pubic symphysis on other hand. It is attached not to the pubic symphysis but to just lateral to the pubic symphysis. It is a fibrous structure which is about 10 centimeters in length. It was previously also called as white line, and it provides level 2 support by this fibromuscular connective tissue of the anterior and posterior vaginal wall at the middle one third of the vagina is getting attached with this Arcus tendinous fascia pelvis, and that is how it supports the middle one third of vagina. Now, what is Arcus tendinous fascia pelvis? It is condensation of endopelvic fascia. Endopelvic fascia is the tissue which is present in the pelvis, and which wherever vessels are there, there is condensation. Wherever nerves are running, there is a condensation of this fascia, and that is how we get various structures such as uterosacral ligament and cardinal ligament as well as this Arcus tendinous fascia pelvis. So it contains mainly the fibrous tissue. It is attached anteriorly to lower and inner border of pubic bone, 4 millimeter lateral to pubic symphysis. This is pubic symphysis, and just lateral to that, 4 millimeter lateral to it is this Arcus tendinous fascia pelvis attached to the lower and inner margin of the pubic bone. Its width is about 5 centimeters. It is around 5 centimeters in length. It runs posteriorly and then it gets attached to ischial spines like this. It is running like that, and while it passes from this pubic bone to the ischial spines, it is coming in contact with this middle one third of vagina, and the outermost layer of the vagina is called as fibromuscular connective tissue. This fibromuscular connective tissue of anterior and posterior vaginal wall is merging with this Arcus tendinous fascia pelvis, and that is how it provides support to the middle third of the vagina. Level 3 support is to the lowermost one third part of the vagina. It is provided by perineal membrane and perineal body. Perineal membrane is nothing but previously called as urogenital diaphragm. It is called as perineal membrane. Again, I am repeating because presence of deep transverse perineal muscle in it is doubtful. There is a doubt about that, and that is why even the latest Teeland is also using the terminology as perineal membrane and not urogenital diaphragm. Teeland's operative gynecology. This perineal membrane forms anterior triangle of a membrane which is present below the pelvic diaphragm. So below levator muscles, we have this membranous structure which is present mainly in the anterior part of the perineum, forming the anterior triangle with a membrane-like structure. So fibrous structure is there. It extends from ischial tuberosities to pubic symphysis. So imagine that the ischial tuberosities, you are holding pelvis in your hand, and there is a structure which is occupying the anterior triangle of the pelvic outlet, running from ischial tuberosities to the pubic symphysis, and that is how it forms the anterior triangle, whereas posterior triangle is called as the anal triangle. This perineal membrane, it separates superficial and deep perineal pouches. That means below the perineal membrane, if you look at the anatomy of the outlet, pelvic outlet, then superficial perineal pouches is on one hand, and deep perineal pouches is on the other hand of this perineal membrane. That is how it separates these two pouches. It forms urogenital hiatus. Now, levator is forming a levator hiatus through which three structures are passing: urethra, vagina, and anorectal canal. Whereas this perineal membrane is forming urogenital hiatus through which urethra and vagina pass. So it supports lower one-third of vagina, as well as it provides important support to the urethra also, that we will appreciate again when we read or when we learn about SUI, stress urinary incontinence. Then it has got important function, this perineal membrane, as it supports the urethrovesical junction also. Perineal membrane and pelvic diaphragm together are forming the pelvic floor. We have already seen in the previous diagram that this pelvic diaphragm and this perineal membrane together are forming the pelvic floor. Perineal membrane extends from ischial tuberosities to pubic symphysis. It is a fibromuscular structure. It forms anterior triangle of the outlet or perineum. Urethra and vagina pass through it. It supports urethra and maintains urethrovesical angle. This is how. These are the two ischial tuberosities, and this is a fibromuscular structure which is running from ischial tuberosities to pubic symphysis, and that is how it forms a membrane-like structure which is occupying the anterior part of the perineum. That is why it is called as anterior triangle. On the other hand, pelvic diaphragm passes from pelvic side walls towards anus or coccyx. It is a fibromuscular structure like this perineal membrane. It is also fibromuscular structure. It contains levator ani and coccygeus muscle. Now here again I want to make it clear. Levator ani is now current textbooks and publications are mentioning that levator ani has only two components, pubococcygeus and iliococcygeus, whereas this coccygeus muscle is mentioned separately, and other name for coccygeus muscle is given as ischio-coccygeus muscle. So this pelvic diaphragm has levator ani muscle and coccygeus muscle. Anal canal, vagina, and urethra pass through it. It supports pelvic floor. It forms the important support at all the three levels of delancing. This pelvic diaphragm, which is formed by levator ani muscles and coccygeus muscle, along with the fascia superior to and inferior to it. This urogenital diaphragm or perineal membrane and this pelvic diaphragm, both of these joined to form the pelvic floor. These are joined together at the perineal body. These two pelvic diaphragm and this perineal membrane are fused with each other at the perineal body, and these together are forming pelvic floor. Perineal membrane or urogenital diaphragm is innervated by pudendal nerves, whereas pelvic diaphragm is innervated by sacral nerves. Because we say in etiology of the prolapse, sometimes there is a neuromuscular damage can also lead to the development of prolapse, and that is why it is important to know the innervation. This perineal membrane is innervated by pudendal nerves, whereas nerve supply of this pelvic diaphragm is by sacral, mainly by sacral nerves. Now, this diagram is to make it clear the relationship between this pelvic diaphragm and perineal membrane. This is how funnel shape, and from up, above downwards is running the pelvic diaphragm, where it has levator muscle, coccygeus muscle, and this white line is the fascia, superior and inferior fascia together, and it is forming the pelvic diaphragm. Pelvic diaphragm is funnel shape. It is formed by levator muscle and coccygeus muscle along with superior and inferior fascia. It is running from lateral pelvic wall to the anus or coccyx posteriorly. Urethra, vagina, and anal canal pierce it, so that opening together is called as levator hiatus. Meaning of the word hiatus is opening. So levator hiatus has three tissues piercing it. On the other hand, perineal membrane, which is also called as previously was called as urogenital diaphragm, it is at a lower level of this pelvic diaphragm. It is going from ischial tuberosity to the pubic symphysis, and vagina and urethra are piercing it. That is why its opening is called as urogenital hiatus, because only urethra and vagina are piercing it. Now, this blue structure is at the middle one-third of the vagina. That is Arcus tendineous fascia pelvis, which is formed by this condensation of endopelvic fascia here. It is running from lateral to the pubic symphysis to ischial spines, but here at the middle one-third of the vagina, it comes in proximity to the middle one-third of vagina, and it provides the support. These two, this pelvic diaphragm and this perineal membrane, they fuse with each other in the center at the perineal body. Again, the same thing, levator are forming levator hiatus through which urethra, vagina, and anorectal canal pass. This is levator, and this is blue one is the levator hiatus, the longer one. At the lower level, we have this perineal membrane, which is forming urogenital hiatus through which only urethra and vagina are passing. This is the red one. Level 3 support is to the lower one-third of the vagina, which is by perineal membrane we have already seen. And second is perineal body. Perineal body, it extends in the midline between vaginal orifice and anal orifice. It extends vertically for 3 to 4 centimeters. It is situated between the vaginal orifice and anus, and it is a tissue which is vertically present with a length of 3 to 4 centimeters. It is formed by fusion of fibromuscular tissues of superficial and deep transverse perineal muscles, bulbospongiosus, and levator muscles. All these muscles in the center, they are merging with each other and forming a fibrous structure, and this fibrous structure is called as perineal body, which supports the lower one-third of vagina. It has a shape of a pyramid with the base at the pelvic outlet. It supports lower one-third of vagina. Now here you can appreciate this is bladder, then we are going posterior, this is vagina, and then posterior most is anal canal, and in between this anal or opening and vaginal opening, in between these two tissues, we have this pyramid shaped body, that is this perineal body with the apex superior and base at the lowermost end, base being inferior. This is together we can see the supports of vagina by delancey as level 1, 2 and 3. Level 1 is apical support by uterosacral cardinal ligament complex. In between these two, uterosacral and cardinal ligament, what we have is, what is separating these two is the ureter. Ureter runs in between. Ureter is just uh, in close proximity to the uterosacral ligament at its origin, and that is why we should never separate uterosacral ligaments or divide them away from the cervix. We need to apply the clamp as near to the cervix as possible, because just lateral to it and at a lower level ureters are passing, and that is why these two ligaments are separated from each other, uterosacral and cardinal ligament. That is level 1 or apical support. Level 2 mid-vaginal support is this fibromuscular connective tissue of the vagina. Anterior vagina and posterior vagina both are having this fibromuscular connective tissue, and that is getting merged with Arcus tendineous fascia pelvis. So Arcus tendineous fascia pelvis is providing support along with this fibromuscular connective tissue surrounding the vagina. Lower 1/3 of the vagina, we have the support by perineal membrane, which was previously called as urogenital diaphragm, and by perineal body. So it is a support at the outlet. Fibromuscular layer of vagina was previously called as vaginal fascia. Now it is called as fibromuscular connective tissue layer of the vagina. Surgical anatomy of pelvic floor at a glance, we can say pelvic floor. When we use this terminology so many times, but what is exactly pelvic floor is, it is formed by two structures, pelvic diaphragm and perineal membrane. Perineal membrane, the older name for that is urogenital diaphragm. These two together form the pelvic floor. Pelvic diaphragm is formed by levator muscles and coccygeus muscle, which are having superior and inferior fascia covering these muscles. Levator muscles have mainly two components, pubococcygeus and iliococcygeus muscle. Pubococcygeus muscle has got the slings such as pubourethral sling, pubovaginal sling, and puborectalis sling, whereas iliococcygeus merge with each other behind the rectum, in between rectum and coccyx, and these two together in the midline form a fibrous structure which is called as levator plate. Perineal membrane, there is a doubt whether it has a muscle component. Whether it has deep transverse perineal muscle running in between is a doubt, and that is why terminology is replaced from urogenital diaphragm to perineal membrane. Pathophysiology of pelvic organ prolapse. Till now we have seen the surgical anatomy. Now what is the exact pathophysiology is, whatever leads to the lower tone of levator muscles and coccygeus muscle that leads to the sagging down of levator plate. Levator plate normally is transverse, but it sags down, which leads to the widening of genital hiatus. As genital hiatus widens, there is more stress on level 1 and level 2 supports. Level 1 is, as we have already seen, apical support, uterosacral and cardinal ligaments. And mid-vaginal is mainly Arcus tendinous fascia pelvis. On these two, the Arcus tendinous fascia pelvis and this uterosacral and cardinal ligament together are acting as suspensions. It is like a tissue which is getting suspended and which remains up because of that. And because of this widened hiatus, these two levels, there is more stress put on these two levels. Gradually, these supports at level 1 and level 2 give way, and that leads to the initiation of pelvic organ prolapse. Now, this levator plate, something about that. It is iliococcygeus, that is part of the levator which passes behind the rectum. This is like that. It is the lateral part of the medial part of the levator muscle is pubococcygeus, whereas lateral part is iliococcygeus. So iliococcygeus muscle This pubococcygeus is there. It is going from the pubic symphysis and it gives a supportive fibers to the urethra, giving a pubo-urethral ring, to the vagina, giving a pubo-vaginal sling-like structure or support, and to the anorectal junction also giving a anorectal sling also. So that is mainly pubococcygeus, which is medial. It is at the near the midline of the pelvis. Whereas laterally what we have is a iliococcygeus muscle, which is arising from iliac bone and going to the coccyx. In the center, these two bones join with each other, and there is a fibrous tough structure which forms because of the joining of these two parts or two-sided iliococcygeus muscle, and this forms the levator plate. Fusion forms a midline fibrous structure which is known as levator plate. It is present normally in it is a straight line. It is like a horizontal structure which is taut structure, which maintains the correct positioning of all these pelvic viscera. It sags down whenever there is a reduced tone of levator muscles. As you can see here, this is a straight line is normal. Sag down means it is like it is becoming now like a hammock. It sags down, and because of that, there is a widening of this levator hiatus. It becomes bigger, and that leads to more stress on level 1 and level 2 delancey supports, leading to the starting point of pelvic organ prolapse. So how POP develops is this levator, again the same thing, levator plate is normally horizontal, and these are the three structures piercing this levator hiatus, that is urethra, vagina, and this anorectal canal. Posterior most will be anorectal canal, then will be the vagina, and then is the urethra. These three are piercing this pelvic diaphragm, and behind rectum we have this horizontally placed levator plate. As this levator plate sags down, that leads to, as you can appreciate as compared to here, this now levator opening is becoming wider because of the less tone over this levator plate, and that because of this widening there is a stress on level 1 and level 2 of the delancey. That means at the upper one third and middle one third of the vagina there is more stress to keep the structure in normal anatomical position is becoming more and more stressful because of this widening of the opening, and that leads to the initiation of pelvic organ prolapse, where either anteriorly anterior vaginal wall along with the bladder might descend down, posteriorly posterior vaginal wall along with the rectum or along with the small bowel can descend down, or at the apex. If weakening is at the apex, then cervix will come down along with the uterus. That is how we have these three compartments: anterior compartment, apical compartment, and posterior compartment. All these will start coming down, descent will start, and that will lead to the development of pelvic organ prolapse. Main supports are pelvic floor, which is formed by pelvic diaphragm and perineal membrane, ligaments, that is uterosacral and this cardinal ligament, as well as condensation of this endopelvic fascia is also forming the third structure, that is Arcus tendinious fascia pelvis, and fibromuscular connective tissue which is surrounding the vagina, as well as it is forming the cervical fascia also when uterus is present. In POP, there is either a break or there are tears in the supportive tissue. Either there is a break or tear in the supportive tissue, or there is a nerve damage leading to neuromuscular damage, or there is a presence of both. There is a neuromuscular damage as well as there are breaks in the supportive tissue, and that is how this pelvic organ prolapse takes place. Now, there is no role of a round or broad ligament or broad ligament in the support of the uterus or vagina. Risk factors are pregnancy and vaginal delivery. advancing age, which is associated with estrogen deficiency and atrophy of the all the supports of the pelvic supports, such as levator and muscle atrophy, as well as there will be atrophy of the ligaments also. Obesity is the risk factor. Constipation, COPD, whatever increases intra-abdominal pressure is a predisposing factor or risk factor for development of prolapse, and heavy weightlifting. Take-home messages: main supports of pelvic viscera are pelvic diaphragm formed by levator and coccygeus muscle, uterosacral cardinal ligament complex, that is level 1, Arcus tendineous fascia pelvis, that is level 2, perineal membrane, which was previously called as urogenital diaphragm, and perineal body at level 3 or lower one-third of vagina. Attenuation is loss of tone. Attenuation of one or more of these supports is responsible for, it leads to the development of pelvic organ prolapse. This attenuation can be either because of the physical breaks or tears in these supporting structures, or it can be because of neuromuscular damage or combination of these two, which leads to the development of pelvic organ prolapse. Now these are the references. What I have seen is, as student, whenever we want to say prepare this topic of pelvic organ prolapse, we open the textbook and we directly go to the chapter on pelvic organ prolapse. You might consider your primary book, either it can be Datta's Gynecology, or it can be Jeff Pott, or it can be Novak, whatever you like, whichever book you like. You will directly go to that chapter and you will start reading about the supports and about the surgical anatomy related to pelvic organ prolapse, and then you will become clueless. You will be clueless. The reason is, all whatever terminologies are being used, what is the exact meaning of these structures, where these structures are placed, everything is given in the first chapter. So if you open till end this first chapter, it is surgical anatomy of female pelvis, that beautifully gives details about all these pelvic organ supports. So first you must read this topic, then only you can start reading pelvic organ prolapse. Unless your base of this anatomy is not strong, you will not be able to understand various terminologies. Novak's Gynecology has also given it in a it has been given quite in a clear manner. That is also that is why I want students to go through that also. And here you can directly go to pelvic organ prolapse, because there is no separate anatomy chapter in Novak's Gynecology related to that. This is one reference which has helped me to understand so many concepts related to this surgical anatomy and supports of the pelvic organs, and that is why I am quoting this reference. And students, those who are interested, or you do not understand some of the terminologies which I am using, then please go through this article. And even images from internet also help us to understand the relationships between various organs and tissues, and it also helps us to draw our own diagrams. Whatever diagrams I have drawn in this lecture, all these are for postgraduate students to practice, so that if you get a theory question, you should be able to draw all these diagrams. One more request to all those who are going through these PGOG video series is, please put your comments in the comment box, because increasing number of subscribers and increasing number of views, that gives me a feedback that my videos are helping people, and it is reaching to the desired audience. But main connect which I feel with my audience is whenever I get a comment, and that is why my request to my audience is, please put your comments. I am eager to know your opinion related to this video, and if you have any queries, or you want improvement in some aspect, or you want any other topics to be discussed, please let me know in your in the comment box. Thank you so much.